enhanced and improved in the years to come. So with that, I'm going to turn it over to our first speaker, who's Professor Ponsiano Ocama. He's very well known around the world as a leader in this area. He's a professor of medicine and hepatologist at Makerere University in Kampala. So over to you, Professor Ponsiano. Thank you.
I'd like to thank the organizers of this meeting for asking me to make this presentation on public health approach for national HBV testing and treatment programs, and in this case, in Uganda. I will start by basically telling you about the overview of the burden of hepatitis B in this country. Uganda has been highly endemic for hepatitis B virus infection. We've had so far 2 national sero surveys in this country. The first one was in 2004, and this reported population average of 10% of chronic hepatitis B. And in 2016, another survey was conducted showing a prevalence of 4.1% again in the population. In both surveys, the prevalence varied from region to region, and the highest prevalence was seen in the north, and with the lowest in the south, and especially the south western region of the country. And there has, up to now, we still do not have any clear data on morbidity and mortality of hepatitis B in this country, but we are now beginning to work on this, and probably next time we are able to report something to you. These actually show the 2 surveys which were conducted in the country, and as you can see, there is that north-south gradient in both surveys, with the highest distribution being in the northern part of this country. But Uganda has also had several milestones regarding viral hepatitis B, and this was because of that high prevalence that was noted earlier on. But initially in the year 2002, Uganda launched the pentavalent vaccine as part of the expanded program for immunization, where the vaccine is given at 6, 10, and 14 weeks post-delivery. And in 2011, Uganda launched the National Health Worker Vaccination Program, where it became mandatory that all health workers get vaccinated against hepatitis B, and whether in private or in public settings. In 2015, Uganda launched the massive nationwide testing of adolescents and adults in a phased manner. And this started in areas which were highly endemic for hepatitis B, and that was in the north and northeastern part of Uganda. And this eventually went into the east, west, and recently we just concluded with the central region. Up to now, close to 4 million persons have been screened, with about 300,000 infected persons identified. And the aim of this, of course, massive nationwide testing was so that all those who were surface antigen negative would be taken through catch-up vaccination, and all those who were positive would be linked to care. And as I talk now, about 4,500 persons are on treatment for hepatitis B in the country. We developed the guidelines for prevention, testing, care, and treatment of hepatitis B, and this was actually completed and launched in the year 2019. And this guideline has its structures for prevention, for testing, and linkage to care and treatment, and then the others included chronic care, especially for those who are not eligible for treatment, as those who are usually eligible for treatment are treated, and they tend to be followed up more closely if they don't get lost to follow up. And then the other aspect was the impact. For testing, all persons really can get tested whenever they would want to be tested. And this testing can be done in government facilities or even private facilities. Priority, of course, in government facilities is given to those on the priority list, which I'm going to mention after this. And a massive screening of adolescents, as I mentioned, was conducted. And this was actually conducted in government facilities. I just want to say that the private units, of course, will provide testing at a fee, which is usually about $3 US per testing. And that is really the rapid testing, which I'm going again to talk about a little bit. All testing in government facilities have been free of charge to those who are being tested. And testing is purely voluntary. All persons with symptomatic liver disease in all health units are actually routinely tested for hepatitis B surface antigen so that we can know what is happening to them, whether hepatitis B is the cause or not. So in the policy, the target population, which I mentioned as a priority list, have included health workers, students undertaking health-related courses, nurses and doctors, pregnant women, people living with HIV or other sexually transmitted infections, household contacts of persons who are infected, sexual contacts of people with chronic hepatitis B, armed forces, the police and the army, prisoners, sicklers or other patients who frequently require blood and blood products, multiple sexual partners, sexual workers, people living with people who inject drugs, and men who have sex with men. These are the persons who are on the priority list. In other words, if testing has to be conducted, these are the people who should be really tested whenever there is any opportunity to have them tested. When persons get tested, they are linked to care. And now here, I am showing you the algorithm that we have been using for the treatment, for linkage to care. And these have included the surface antigen test. And if it is positive, the assumption is that this is chronic hepatitis B. And I think generally that is what it is like. And so we run the blood count, liver function tests, and of course HIV is mandatory. And then we compute the FPRI. HBV viral load is actually currently tested for in Uganda for free. And so using these categories, the patients are graded into 4 categories. Category 1 are those who you will have to treat with or without viral load anyway. And these are the persons with cirrhosis and or APRI score of more than 2. Category 2 are those who are eligible for, these are the persons who have HIV. Those are automatically eligible for treatment. Fortunately, because of the test and treat policy for HIV, these patients usually just get treated anyway. Unfortunately, they are put on 2 medicines active against hepatitis B and HIV as well. So they are taken care of a little bit better than others. We have category 3, those persons who have APRI score less than 2, ALT are persistently abnormal, and we are doing 3 values 2 months apart. And so at least we have 2 values with elevated ALT, and we cannot explain the reason why the ALT is elevated. For example, they're not taking a lot of alcohol and viral load of more than 20,000. These are people that we actually treat. But the category 4 are those ones who do not fall in any of the 3 categories, and they're usually monitored annually. And this is similar, very similar almost to what we do with what we have with it in the WHO guideline. So the testing modalities, usually Again, the surface antigen is the initial test, and this is done in the government or private facilities. Rapid tests are used. In the country, we have got the SD Bioline, the Orchid or ViroCheck, and then the Astra. These are the ones that are actually recommended by government to be done, to be used for testing for hepatitis B surface antigen. Now, all those who test positive for surface antigen, irrespective where they are tested from, they are usually referred to regional referral hospitals where further investigations are done. And these hospitals actually have what we call hepatitis B clinics. These patients basically go there and they are seen by the clinicians. And when they reach there, the tests which are done include those indicated: blood count, liver function tests, renal function tests, and the hepatitis B viral load. Now, the viral load is actually done at one center in Uganda, which is a central public health laboratory, which is under Ministry of Health. And samples are taken by courier from all regional hospitals in the country, and they are taken to that very lab. And this has been used for HIV as well. So this we were piggybacking on this HIV system to also help with the transportation of samples for hepatitis B. And the results are usually out within 2 weeks on dashboards. And every center that has sent samples receive their sample results within 2 weeks, and they're able to share it with the patient. Then all persons who have tested positive for hepatitis B surface antigen and are at the care centers, at the regional centers, they are all they are allowed at least 2 hepatitis B viral load tests per year. And this is very critical because we use this for monitoring the response for treatment, especially in those who are really on treatment. So this is basically the packaging of the samples for the hepatitis B viral load. Reporting and linkage to care. These patients, usually when they reach those regional centers, they get a post-test counseling. Many times at the various sites where testings are being done, there's no very good testing, and that is a challenge for us. But once they reach the regional centers, the post-test counseling is done, and the patient from there is sent to the clinician where enrollment takes place, and then the results of the assessment to decide whether they really require treatment or not is done at that point. But even those who do not require treatment, they are automatically, put on schedules for regular monitoring. So I will now talk a little bit about hepatitis B in pregnancy. Now, again, it is an algorithm which I want to share again. There's this essence of hepatitis B, HIV, and syphilis triple elimination program. And this is what is actually put in our guidelines. And so for all those mothers who are surface antigen positive, we run their viral loads, and we are running this viral load. We do the e-antigen and the viral load testing, and we use the same courier mechanism to actually send the samples to the Central Public Health Laboratory. And we initiate prophylactic treatment at 24 weeks of gestation, but can be considered at the earliest contact. And this is usually done in all those patients who are e-antigen positive and more than 200,000 international units of the per male of the virus. And we discontinue this treatment at the end of 3 months. And after completion of this, after discontinuing the treatment, the patients or the mothers are monitored for 8, 12, 24 weeks. And then annually, we keep monitoring them with viral loads at 6 months and then 12 months. Now they join into the regular care like the others. Now, of course, for mothers who, anyway, from the very beginning, have indications for treatment, as is listed in the categories. They are started on the treatment, and they are now, treated and followed up for life while they are on this treatment. And this is what we are following in the guideline. Now, the challenges of this is, first of all, we are having some issues with the test kits. We do not have adequate test kits. And although this is a requirement at the various sites, including private and public hospitals and health units, we do not have adequate kits. And the areas where we did the massive testing, not everybody got tested. But we've not been able to get back to do mop-up testing to actually get the numbers, the number of people who could be enrolled into care. Then we have a challenge with the birth dose vaccine in our facilities. Currently, actually, we do not, although it is in the guideline, we are not having any significant birth doses in the health facilities. And so this is quite frustrating to a number of people, because this would be one of the best ways of curbing the transmission of this infection. We have also issues with infrastructure at the referral sites, the HBV clinics. We have issues with human resource and lab capacity, and sometimes even space where we are supposed to see these patients. And the patients are therefore, some patients get lost to follow up. In fact, a number of the patients that were in the screening program, a number of them eventually, those who reached eventually dropped out, and some people did not actually even reach the centers. For example, in one of the districts in northwestern Uganda, where 218,000 persons were screened, and 14,176 were found positive. When we tracked the record from the district offices, we could only find 2,209 in being traced in care. And some of those, even the 2,209, some of them were got lost to follow up. And these are actually big challenges. So what are the operational research opportunities? First of all, we want to look at the issue of loss to follow-up. And this loss to follow-up is a big issue for us. And we are thinking that in those areas where HIV infrastructure has been existing for some time, moreover with the donor funding, where health teams, village health teams go to the villages to look for these persons who have not come back to the clinic. We are saying, why don't we get them, the same team, to go and also talk about this hepatitis B, and then so that we can begin to get some of those people back. Radio talk shows could be done, and this would certainly be very helpful. A number of patients presenting with advanced liver diseases post-screening, we see them in the hospitals sometimes, not systematic research being done on those. We think that we need to now do this research systematically so that we can get the national burden of chronic liver disease due to hepatitis B. We are also trying to see the possibility of really integrating HBV care in the HIV clinic, because they seem to be well funded. The HIV clinics are well funded, and this should be able to give us a good outcome. Introduction of hepatitis B birth dose and testing the effectiveness of the guideline algorithms on PMTCT would be something, again, really that we need to look at. Thank you very much. And again, thank you for inviting me for this presentation. I'd like to
Thank you very much, Professor, for the excellent presentation on the policy and programming in Uganda. There are already quite a few questions that have been posed to you in the chat box, as well as the question and answer. If you could work on providing some answers to those requests in the chat box and question and answer, I think it'll spur some more discussion in the subsequent presentations. Professor, if you're able to come on camera, we could just ask one follow-up question here. Professor, are you available to come off mute and on camera?
Yes, I don't know if you are able to see me.
Yes, we can see you. Thank you so much for the excellent presentation. Professor, I think there were a few questions that have already been posed in the chat box for you. But one, I think the general theme there is that there's an impressive policy in place in Uganda, but apparently, there's a gap with achieving that policy in some of the programming. So I think some of the questions were in regards to how do you reach rural populations, or what might the coverage of these free services be for those rural populations living in Uganda? So what's the actual coverage, and what's the actual availability for individuals, in rural areas to access testing for hepatitis B?
Thank you very much. I think I would say first of all, when we were doing the national screening, it was actually done at grassroots level almost. Everybody could go and would be tested. But as I mentioned in the presentation, the areas where the where the screening took place, the areas which were left, there was no mop-up, screening. But testing is still being done, but certainly at much lower rates in the different health units, especially in the district and regional hospitals. So at lower health units, it's not as well covered compared to the higher health facilities. But in all those cases, wherever the screening took place, for patients or those who tested positive, that could be contacted, were able to get their samples, and they were taken to the national testing center for the viral load. But then some of them, after that, couldn't be traced again, even if they had the results at the centers. So it was a little bit tricky. It's a little bit difficult to get those ones back, and that's why we are saying we need to get back and begin to trace those people who tested positive, and that we can't see now in the health facilities.
As a follow-up to that question, Professor, is there a registry in Uganda for all individuals who test hepatitis B surface antigen positive?
Yes, they are all entered into the health information management system of the Ministry of Health. And so we are able to actually get that information from the Ministry of Health records. And at local levels, we get them from the district health officers, the offices in the district health office, where we actually get all, from there, they actually send them to the Ministry of Health. Yeah.
Wonderful. So we're going to move on to the next presentation, but Professor, if you could take just a moment and